Hi guys, this is Alicia with Good Morning Sunshine. So today we had 3 lectures, had those lectures already. I know it's early, still, and then I have lab this afternoon, so I decided to come home and get stuff done, make my video so I don't have to make it tonight, and then, prep for tomorrow, when I get home later. But today we had biosecurity, so I'm going to start with that. So our objectives here are to define hazard reduction, to define biosecurity and infection control, and to describe tools needed to implement biosecurity and infection control, and then to differentiate between cleaning from disinfection, and then to list factors that alter pathogen exposure, and then to define zoonotic organisms. So we have this diagram here. So first we start with workplace management of hazards such as pathogens, chemicals, and equipment. So we have the hierarchy of control table here. So of course, eliminating the hazard is the best. And then substitution, that has to do with like vaccines. So that means like replacing the hazard. And then we have engineering controls, which one person would go in a room instead of like all 5 of us. So that's like engineering, 1 person goes in instead of 5 being infected. It would just be that 1 person, if that makes sense. So engineering controls means to isolate people from the hazard. And then we have administrative controls, which means we have to change the way people work, which is very hard sometimes because it's hard to change people's ways. So that's like washing hands. When vets or just doctors in general walk in somewhere, they're supposed to wash their hands before touching you or an animal, and then when they leave, they're supposed to wash their hands again. And then lastly, we have PPE, which is to protect the worker with the personal protective equipment. So that goes along for vets. That's like caps and surgery, scrubbing, and all that, or just wearing all the PPE. We know that with COVID because we had to wear a lot more of that. And then we got into the transmission of infectious agents. That it requires 3 elements. The first element is a source or reservoir of the infectious agent. And then the second is a susceptible host with a port of entry receptive to the agent. And then lastly, we have in the mode of transmission for the agent. So then he talked to us about a mission statement. So it says, I or my client, and then we had to fill in the blanks. So this was our first blank, but for the whole mission statement, it should be, I must create a program to eliminate the risk of all diseases that are preventable. However, this depends on the C's, because we're never gonna get rid of like salmonella, so we can't totally eliminate that, but we can at least decrease or manage it. So yeah, it just depends on the pathogen or disease. And then we had this. So we have the cows on the left side are infected in red, and then we have the cows on the green side, which are the clean cows. But are they safe? That was basically the question we were asking. So a majority of them are not infected, and they are separated, but this also depends on different variables, such as the wind, like which way the wind blows. So you don't want the infected cows, the wind blowing towards the clean cows, so they would get infected by respiratory reasons. So it depends if they're safe or not, depending on how far away, what location are the clean cows up higher, so the air doesn't hit them. So there's all these variables that go into this. Also, if the same person is feeding the clean cows as the infected cows, that vet would want, or the person feeding them would want to do the clean cows first before they even touch the infected cows, because if it goes the wrong way, then the clean cows could easily get infected. And then we also looked at sheep here. So now we have the red cows that are infected and the sheep that are not infected, or the clean sheep. So this depends on the pathogen itself. So it depends if, so like salmonella, blue tongue, or parasites can go between species. So again, it depends on the organisms and if they're species specific or not, if those pathogens are species specific or not. So it could be bad or good mixing animals like that. So then we have the disease triangle, which is also known as the epidemiological triad of causal factors. So we have the agent, of course, which is virulence and infectivity of a pathogen and additive qualities of a substance of abuse, etc. And then we have the environment, which has to do with sanitary conditions, social context, availability of healthcare, etc. And then we have the host, which has to do with genetic susceptibility, resiliency, nutritional status, and behavior. So we need all three of these to make it work. So then we got into the actual definition of biosecurity. So it means all the cumulative measures that can or should be taken to keep disease from occurring and prevent the transmission of disease. So the policies and hygienic practices designed to prevent incidents of infectious disease. There was also another definition that he included for biosecurity, which had three different things. It had the stringent bioexclusion, which means to keep the agent out. And then you have ruthless biocontainment, which means to keep the agent in. And we have, lastly, the early detection vigilant surveillance, which is to find out who needs to be contained or excluded. So 3 levels of biosecurity. We have conceptual. So this is like where do you place the surgery suites, the isolation facility, etc. Then we have structural. That has to do with square footage, positive or negative ventilation, and ante rooms. And then we have procedural, which has to do with patient prep and cleaning protocols. Scabo! What are you doing? Sorry, this guy left the room. And then we have our instructions opinion on biosecurity. So biosecurity or infection control, we use our SKAs, which are skills, knowledge, and attitude or aptitude to prevent a disease or infection that is preventable. So then he gave us this quote that all I maintain is that on earth there are pestilences and victims, and it's up to us as far as possible to not join forces with the pestilences. So then we got tools in our toolbox for an infection control plan. So we need knowledge of the pathogen, so detection, route of transmission, and alternate host. And then we need to know the identification of infection or disease. So signs and consequences of infection versus disease. So testings versus vaccines for like COVID reasons. And then what's better to know? Is it better to know who's sick or know who is spreading the disease? So here we were testing people for COVID, but then they switched to vaccinate people for COVID. So vaccines prevent the disease, not the infection. So we're kind of back and forth on this spectrum of is it better to know who's sick, and then that's when we test them for COVID, but then and then who's spreading the disease. That's why we got vaccines going now. So then we have the BSL 1 through 4. That we use in veterinary medicine, so we must follow these depending on which one is assigned to us. So BSL 1 has to do with appropriate for work with well-characterized agents which do not cause disease in healthy animals or people. And then there's a BSL 2, which is appropriate for work involving agents of moderate potential hazard to animals or humans. This includes various microbes that cause mild disease in animals or people where a treatment and or vaccine may exist. And then we have BSL 3, which is appropriate for work involving microbes, which can cause serious and potential fatal disease in animals or humans for which there is a treatment or vaccine. And then BSL 4 is the highest level biosafety precautions and is appropriate for work with agents that cause severe to fatal disease in animals or humans for which there is no treatment or vaccine. So we have a few other definitions. We have nosocomial, which is healthcare associated infection or hospital acquired infection, also known as the HAI. So did the animal come in clean and left dirty? So this is when the infection is spreading within the hospital kind of thing. So an animal comes in clean, but then gets something within the hospital and left. So this is an infection that is acquired in a hospital or other healthcare facility. So then we have community associated acquired infection, also known as CAI. This is when people walk through the front door, animals walk through the front door. We have no idea what they're bringing in. So this is an infection contracted outside of a healthcare setting or an infection present on admission. And then we have zoonosis, which is an infection that transmits from animal to man or man to animal, so like zoonotic. So we have more tools in our toolbox for an infection control plan. So we have cleaning and disinfection, which these are 2 separate processes. So you want to remove organic debris. So that's where you're cleaning, and then you want to disinfect after that. And then another tool is enhancing health status of animals. And the last one is the ability to change the behavior of people. So again, going with clean first and then disinfect. So you're going to remove gross organic matter. You're going to apply detergent and water. Then you're going to rinse with water. And then you're going to apply disinfectant, the chemical, allow required wet contact time. And then you're going to rinse with water and then dry. Seems easy enough, but this is why we scrub and why it takes vets so long to scrub, because we want to get in the habit of giving that disinfectant contact time. So is it a blessing or a curse to bring multiple sick species under one roof? So it kind of depends. This can't be answered with a yes or no. It depends if the disease crosses species or not, and sometimes multiple animals under one roof is an advantage, but it can also be a disadvantage at times too. And then we got this picture. Are humans worried as our dog's licking our face? Well, we at least wash our hands once in a while, right? So then we have that, and then we got into PPE, so barrier protection. We all have seen PPE. Basically, this is just protecting us from spreading, so it's protects us, but as well as spreading it to you. So this is a protection, protects patients from other patients and you too. So then we got into healthy animal versus herd relative to infectious diseases. So if resistance is higher than the pathogen present, the animal will stay healthy. However, there can be a cross. So when the pathogen load is getting higher, whereas resistance to the disease is getting lower and it hits in the middle, that's when you get a sick animal. And then we asked, are most cases of hospital-acquired infections due to decreased resistance, increased pathogen load, or both? So here resistance is down. Here's our graph here. Resistance is down, which is the black line, and then we have the pathogen load is up. Thus here you would get a sick animal. So it depends on both. It depends on decreased resistance. It also depends on increased pathogen load. So it depends on both. So does a biosecurity infection control program affect both lines equally? So infection control. So we realize lines are moving. So we have to do something about it. So when we notice that there's a decrease in resistance or there's an increase in pathogen load, we need to do something about it. So we need to identify it and put in an infection control plan. So factors that influence resistance to disease is previous exposure to the pathogen, so like natural exposure or vaccination. Also maternal immunity in neonates, adequate nutrition, immunosuppression and stress, and genetic selection in animals. We also have factors that influence pathogen exposure, such as sanitation, adequate ventilation, presence of or absence of infected diseased animals, the presence or absence of vectors, and hand washing versus PPE. So lastly, developing an infection control plan. So we make a plan that controls all known pathogens or just the last 3 in your clinic. So we have dots for VTH. That's what he said he did in his veterinary hospital. So green was mean the animal's normal, like they're clean. And then we had yellow, which means increased risk of getting infected, so like neonates. And then you had the color orange, which means increased risk of being infected, so like non-healing wounds. And then we have red, which are highly contagious pathogens that are going straight to like contagious or like the ICU. So in summary, you need a plan, preferably written. You need to train repeatedly because humans are trained that way. And then you need to model professional behavior. So if I'm the boss, I need to show my people that I'm doing the same thing that I taught them to do in that matter. And then we also need to monitor the outcomes of the plan and adjust accordingly. So that was our biosecurity lecture, which I kind of enjoyed actually. And then we got into our clinical pathology 3 lecture, which had to do with bilirubin and hemolysis. So he went over like everything we also went over. So here's a table of this too. So we have microcytic, which has to do with iron deficiency. So there's a low MCHC. Portosystemic shunt, so that's like a liver shunt. It's unknown mechanism, but its support is high ammonia. It's in a lot of Japanese breed dogs and in fells that are less than 6 months. And then we also have hypochromic, which also has to do with iron deficiency. So this is a low MCV. The support is increased reticulocytes. And then we have normocytic. Sorry, I should have went that way first. And then that means anemia of chronic disease. And then we have macrocytic, which has to do with erythroid regeneration. So the support is the reticulocytosis. It has a positive or negative concurrent low MCHC, red blood cells, agglutination, so artificially high MCV. And then this is usually in some poodles, has to do with FELV infection in cats, and then cobalamin, I can't even say that, deficiency. Then we also have, so I went from hypochromic and now we're normochromic. That means anemia of chronic disease as well. And then we have hyperchromic, which is not really real. This is a result of an artifact, so in vitro or in vivo, intravascular hemolysis, numerous Heinz bodies, and lipemia. But yeah. So bilirubin has to do with metabolism, pathologic conditions, and serum profiles. And then we have hemolysis, which has to do with intravascular hemolysis and extravascular hemolysis that we're going to go over in this lecture. So we have bilirubin metabolism. So the key players are the hepatocyte. They join the canalicular space, which goes to a portal triad. And then from spleen, the blood in the spleen goes to the portal veins, which mixes with the hepatic arteries blood, and then it rises to the portal triad. And then they go through the sinuses, of course, and then go into circulation. So again, in past lectures, we know that heme has a porphyrin ring and iron. The ring is changed into unconjugated bilirubin, and then old red cells are removed by macrophages. So then the unconjugated bilirubin is a waste product and it is not water soluble. So we have to do something about that to get it to the liver to excrete it. So we need to combine it with albumin, which allows us to go through the portal veins into the sinuses, and then it gets conjugated, which means it is now water soluble and it can be freely excreted by the liver. So transport from the hepatocyte to the canalicular space. I'm not going to show you the diagram because it will be very confusing to you. So albumin and unconjugated bilirubin are present in the kidney. Dogs can have conjugated bilirubin in its urine. So we needed to know that. That's probably going to be an exam question. But cats, on the other hand, you rarely see conjugated bilirubin. So then we got into hemolytic anemia, which means red blood cells being phagocytized by macrophages again. More unconjugated bilirubin is produced. Thus, they would have to be bound by the hepatocytes. And then some unconjugated bilirubin gets into the blood plasma, so thus we would see increased levels of bilirubin. So the red cell turnover is breaking down at a faster rate, so animals start to get icteric. So this has to, hemolytic anemia has to do with icteric here. So we get into the cause and mechanism of hyperbilirubinemia. So hemolysis, you would see increased BU production, and then increased red blood cell destruction from oxidative injury, primary and secondary immune-mediated destruction, hemic parasites, increased red blood cell fragility and shearing. But in anemia, it's regenerative, it's supporting red blood cell changes such as hind bodies, spherocytes, and parasites. So then we got into fasting hyperbilirubinemia, which I was just talking about here. So before we were talking about hemolytic anemia, and now we're talking about the hyperbilirubinemia. So fatty acids are competing with receptors that usually take up the unconjugated bilirubin. Thus, unconjugated bilirubin gets backed up because they no longer have these receptors that bring them up in order to get excreted. So we would then detect unconjugated bilirubin in the plasma here too. So again, I'm going to go over the cause and mechanisms of the hyperbilirubinemia. So anorexia, so in horses, is usually less than 10 milligrams per deciliter. Decreased uptake by the hepatocyte of bilirubin and or decreased conjugation of bilirubin. So with anorexia, there's increased fat lipolysis, and FFAs compete with bilirubin uptake by the hepatocyte, and horses use glucose instead of glucuronide for conjugation, so decreased conjugation may contribute. And then the support findings for this, or the history of anorexia, is the BC is normal. I think that means blood count. I don't know, actually. And then the GGT is normal unless there is a concurrent hemolysis or RDDLC. So then we got into functional cholestasis, where the bilirubin can't get excreted from the body, thus increases in hepatocytes, then diffuses back into the blood. We will then have increased conjugated bilirubin in the blood, so not unconjugated like hemolysis or the fasting bilirubinemia. So this has to do with increased conjugated bilirubin in the blood. So the causes and mechanisms of this, so functional cholestasis, it's impaired excretion of BC from hepatocytes into the bile caniculi due to infection. So it's mediated by the TNF alpha and others. The support findings have to do with inflammatory leukogram, but you would expect a normal ALP and GGT. And then we got into obstructional cholestasis, which is the increased conjugated bilirubin in the plasma, just like with the functional cholestasis. There's no caniculus, thus can't secrete bilirubin here. So then we got into obstructive cholestasis, which is the decreased excretion of conjugated bilirubin. So hepatically, it's obstructed bile caniculi, like I said, or bile ductules or bile ducts, which causes the hepatocyte swelling. So lipidosis and the infiltration of hepatic parenchyma and or portal areas with neoplasia, such as lymphoma, infection and inflammatory leukocytes, fibrosis around portal areas, and migrating parasite stones. And then we have the post-hepatic obstructive cholestasis, which has to do with the pancreatitis, cholelith, the gallbladder, inflammation, infection, the pancreatic bile duct, or in the intestine neoplasia causing an obstruction. So support findings for this one is concurrent increases in the GGT and ALP. With pancreatitis, you have inflammatory leukocytes, hypocalcemia, and dehydration. You may need AUS for differentiation of hepatic versus post-hepatic here. So this is just an overall overview of what kind of blood or bilirubin it has to deal with. So like I said, in hemolytic disorders, you have increased unconjugated bilirubin in the blood. For fasting hyperbilirubinemia, you have increased unconjugated bilirubin in the blood. But for functional cholasis, the obstructional cholestasis, and that's the hepatic, and then we have the post-hepatic obstructional cholestasis, which these all have to do with increased conjugated bilirubin. So it's the opposite of the hyperbilirubinemia and the hemolytic disorders. So then we got into intravascular hemolysis. So here you would see ghost cells and the plasma is red. So that's the main point we need to know about these. But it's at the site of red blood cell destruction, such as blood vessels, and the initiating processes have to do with antibodies yielding membrane attack complex complement, and the red blood cells infectious agents, as well as oxidative injury. And then we have extravascular hemolysis, where you would see spherocytes, and the plasma here is yellow due to icterus. So this is the site of, again, red blood cell destruction. It has to do with macrophages, though, in the syncytial capillaries. And the initiating process is antibodies yield opsonization, and the red blood cells is the infectious agents, and then we have oxidative injury and old age markers. So in intravascular hemolysis, the complement cascade gets activated. You get lysis of red blood cells, and the hemoglobin released into the plasma, so the MCHC goes up. And again, the ghost cells are here in the red, you would see. And then with extravascular hemolysis, the complement is involved, so IgG is involved here. Opsonization happens with this. There's macrophages, see this, and phagocytize the red blood cells, which means increase. So you have spherocytes here, like I said. And so I'm going to show you this picture. So you have normal right here, but then here you can see actually some ghost cells, but as well as spherocytes. So here, in this case, you have spherocytes and ghost cells, so you have intervascular as well as extravascular, in this case, hemolysis. So then we finished that lecture, and then lastly we got into immunology 2, which had to do with hypersensitivity reactions. So it's also called immune complex hypersensitivity. So the mechanism for combating extracellular bacteria, there are 2 types. There are antibody excess, which you have low antigen here, but you have high antibody ratio. It's the formation of immune complexes at the site of antigen penetration and the local tissue inflammatory reaction. But then we also have antigen excess, which is high antigen with low antibody ratio. So we have the formation of immune complexes in the blood, and then the vasculitis in multiple tissues such as the kidney, joints, eye, and skin. So then we have type 3 antibody excess. So again, we first deal with sensitization. So antigen again gets across the barrier here and ingested by a phagocyte, which makes it way through to the lymph node, and then there's repeat exposure of the antigen. So this having to deal with Th2 helper cells. So the IgG antibodies that bind to the antigen, there are receptors on the macrophages that release the interleukin 1. The complement is activated by the immune complexes. And then we have C3a and C5a, which stimulate the mast cells to degranulate here. And then we have mast cell activation. So there's at least 3 mechanisms for this. We have the direct interaction with pathogens. We also have the binding of IgE to Fc receptor type 1. So we talked about binding of the IgE to Fc receptor. So that was type 1 sensitivity, which I went through earlier. And then we have complement mediated activation, which has to do with type 3 hypersensitivity. So again, type 3 hypersensitivity, antigen excess. So repeated exposure to an antigen, little bits of antigen, but at many times. It's also called Arthus reaction. Hypersensitivity pneumonitis has to do with humans, cattle, and horses. It's repeated exposure to mold, bacteria, and other airborne allergens. It's usually small particles that pass through the airways to the lungs. And it can also have a complement of type 4 hypersensitivity, which we'll talk about in a minute. So how does this differ from type 1 hypersensitivity? Well, type 1 has to do with typical allergies, whereas type 3 has to do with more like chronic lung disease. So it has a slower onset of clinical signs after exposure. There's no IgE here, has to do with IgG. Eosinophils are not prominent here, but like they are in type 1, and then there's more neutrophils in here initially, and then lymphocytes and plasma cells later. So then we have antigen excess type 3 sensitivity. So the immune complex is formed in the vessels. It deposits in the wall of the small capillaries. So this has to do with the renal glomerulus, the synovium of joints, and the uveal tract of eyes, and the epidermal basement membrane. So we have complement fixation, vasculitis, and thrombus and ischemic necrosis. So then we got into cutaneous vasculitis, which is an immune complex deposits in the basement membrane of the skin. So there's common locations of the pinnae, the paws, the nose, and the tail. The lesion description is well demarcated and often target-shaped. So I don't know if you can see these pictures here, but this is a paw, has lesions, and then that's an ear of a dog. And then we got into immune-mediated glomerulonephritis, which is our immune complements stuck in the vessels causing complement immune damage, and then the albumin leaks and is filtered out in the urine. So the immune complex deposition in glomerular basement membranes, it disrupts filtration barrier. There's loss of protein in the urine, so protein losing nephropathy. So it has to do with hypoproteinemia, edema, effusions, and proteinuria. So here we have the normal glomerulus here, and here we have the glomerulonephritis. So then we're getting into type 4 hypersensitivity. So antibodies are not involved in this one. So you have delayed or cell-mediated hypersensitivity. You have the onset between 24 to 72 hours after re-exposure. And then it's unlike types 1 and 3. Like I said, antibodies do not play a significant role here at all. So here, some antigens get stuck in the barrier, and this type 4 has to do with Th1, so helper 1 cells. So the Th1 bind to the antigen, they release the interferon gamma, they release macrophages, and also release a TNF, which recruit neutrophils, and then the TC can call on apoptosis. And then we got into contact dermatitis, which has to do with like poison ivy. So you get sensitized, you get re-exposure, which leads to inflammation and swelling. So here's like a chart that we went through. So on this side we have atopic dermatitis, which is a type 1 hypersensitivity, and then which we reversed it to an allergic contact dermatitis, which has to do with type 4 hypersensitivity. So the clinical signs for atopic dermatitis, which is the type 1, clinical signs here are hyperemia, urticaria, and pruritus. And then the distribution is the face, nose, eyes, feet, and perineum. And then the major allergens are foods and pollens, fleas, inhaled allergens. And then the diagnosis is intradermal testing, immediate response. The pathology is eosinophilic infiltration and edema. And then the treatment would be steroids, antihistamines, and hyposensitization. Whereas the allergic contact dermatitis has to do with the type 4. Its clinical signs are hyperemia, vesiculation, alopecia, and erythema. And then the distribution has to do with hairless areas, usually your ventral abdomen and feet. Its major allergens are reactive chemicals or dyes in contact with the skin. Its diagnosis has to do with delayed response on patch testing. Its pathology is mononuclear cell infiltration and vesiculation, and then its treatment is also steroids. So they're a little different. So I guess the professor had a junkyard story where she got bit by a ton of mosquitoes, so it was very itchy, which that would be type 1 hypersensitivity. And then she also ran into poison ivy, which would be type 4 hypersensitivity. So then we got into the tuberculin skin test, which is the identification of animals infected with mycobacterium. We inject purified fragments of dead mycobacteria under the skin. We wait 3 days, assess for swelling at the injection site. So the gross changes here are thick and firm erythematous lesion at the site of injection. Its microscopic changes have to do with mononuclear cell accumulations around small veins and venules, edema, hemorrhage, fibrin deposition, and endothelium hypertrophy. Then we got into mucocutaneous diseases, its conditions being arrhythmia, multiforming, Stevens-Johnson syndrome, and toxic epidermal necrolysis. And then we have T-cell mediated hypersensitivity to drugs. We have drugs bind to epidermal cells, the T-cell mediated apoptosis, skin loss, and can be life-threatening. So overall, here is our chart of between type 1, type 2, type 3, and type 4, which I went over all of those, so I'm not going to go over with you again. So then we have veterinary dermatology, which has feline allergic diseases, so introduction and proposed nomenclatures. So we have feline atopic syndrome, which has to do with allergic diseases of the skin, the GI tract, and the respiratory tract. And then we have feline atopic skin syndrome, which has to do with allergic skin disease associated with environmental allergies. We have feline asthma, which has to do with eosinophilic inflammatory disease of the bronchioles. And then we have feline food allergies, which is clinical manifestations attributed to immunological reactivity to an ingested food item. And that was the end of hypersensitivity part 2. So type 3 and 4 hypersensitivities, and then I already went over type 1 and type 2. So that was it for today. I'm just waiting to go to lab. I'm gonna work on prep for tomorrow. And for the next few days, try to get ahead because we have an exam on Monday. So this weekend's all about studying again. Yay. But I love you guys, and I thank you guys for watching.